Chapter 27, we will talk about child with a condition of the blood forming organs or lymphatic system. Before we continue, we'll talk about the point in gestation as to when the plasma and the blood cells are actually being developed. So plasma and blood cells are formed at about the second week of gestation, and this is actually when we did talk about the yolk sac, that is actually primarily in the yolk sac. And then later on, the blood forms in the spleen, liver, thymus, lymph system, and then the bone marrow. While the baby is still inside the womb, then the liver is the one that's responsible for formation of blood. After the child is born, then we all know that the red blood cells, they are now being formed in the bone marrows, the marrow of the long bones. And by around the adolescent time, that's when the formation of the RBCs can also take place in the sternum, in the vertebrae, in the pelvis, skull, clavicle, scapulae, in addition to the marrow of the long bones, which is your tibia and your femur. The substance that we call erythropoietin, this is the one that is actually regulating the RBC production. And while the child is still inside in the womb, while they're still the fetus, then it's also the liver that's responsible for the RBC production for this erythropoietin. Now, when the child is born, as we have mentioned before, erythropoietin is being regulated by the kidneys. All right. Going back to what is normal with the newborn will have a high hemoglobin, high red blood cell count at birth, and high white blood cell. And all of those will slowly decrease to a stable level. Also, we did mention during OB class that newborns, they do not have this what we call vitamin K, and vitamin K is actually helpful for the blood clotting factors. That's why we give this vitamin K right after birth. All right, now let's talk about the lymphatic system. Your lymphatic system, this includes the lymphocytes, the lymphatic vessels itself, lymph nodes, the spleen, the tonsils, the adenoids, and the thymus glands. If you look at figure 27.1, this is page 639 in the book. It's actually showing us a good picture of where we can find those lymphatic system, the structure for your lymphatic systems. So we now know lymphatic system drains regions of the body by our lymph nodes. What they do is they try to trap whatever pathogens that comes inside the body, and hopefully we can catch it and we can destroy it, right? This is where the infectious organisms are destroyed in the lymphatic system. This is also where our antibody production is being stimulated. So think about that function of your lymph nodes or the lymphatic systems. That's why this is where we call lymphadenopathy. This is the enlargement of the lymph nodes, and it's actually an indicative of infection or a disease. So a little review, if you look at page 639 again, that figure 27.2. Look at the red blood cell, the erythrocytes, um, and the shape of it, the normal shape of that, and then the platelets, or what we call thrombocytes. Then under your white blood cells, which we call leukocytes, you have your granular and you have your non-granular. For your granular leukocytes, you have your basophil, your neutrophil, eosinophil, and then for your non-granular leukocytes, you have your lymphocyte and then your monocyte. Okay, spleen. Spleen is the largest organ of the lymphatic system, and one of the main functions is to bring blood into contact with the lymphocytes that help us combat or catch those pathogens, and then hopefully we can destroy it. The most common pathological condition is enlargement of the spleen, which is what we call your splenomegaly. Usually, like I mentioned earlier, is when these organs of your lymphatic system is enlarged. This is indicative of infections, either congenital and acquired, and it could also be an indication of those acquired conditions like your hemolytic anemias and liver malfunction. Blood. So blood consists of two portions, right? We know that. There's plasma and then there is formed elements. Plasma is the liquid component of the blood, where the other part of the blood is your formed elements, where we call your erythrocytes, your red blood cells, your leukocytes, which is your white blood cells, and then your thrombocytes, which is the platelets. Okay, function of your erythrocytes or our red blood cell is to transport oxygen and carbon dioxide to and from the lungs and tissue. When we talk about the conditions of your respiratory system and the cardiovascular system, so blood plays a big role to that, because blood is the one that's actually helping with those transporting of oxygen into the lungs, and then transporting the carbon dioxide from the lungs to outside of the body. Leukocytes is our white blood cell, and this one acts as the body's defense against infection. Then in addition, your thrombocytes, let's not forget our thrombocytes, that is the one that is involved with a blood coagulation. Okay, your lymphocytes, which is one of your non-granular leukocytes, your white blood cell, this one is actually produced in the lymphoid tissues of the body. So they are being produced, they are being stored in that lymphoid tissues of the body. When a pathogen comes and actually start an infection in the body, that's when this lymphocyte starts to travel to the site so that they could help with combating that infection. Okay, so now that we remember the functions of the blood and the white blood cells and your thrombocytes, now let's talk about the disorder and those manifestations that happen if something went wrong with those functions of the blood or blood forming organs or the lymphatic system itself. So first one is your anemia. Anemia can result from many different underlying causes. It is defined as the reduction in the amount of your circulating hemoglobin, and in return, it reduces the oxygen carrying ability of the blood. When we say that it can result from many different underlying causes, like for example, you can have your iron deficiency anemia, which is something to do with the iron in the body, or you could have sickle cell anemia caused by the sickle cell um, disorder, or aplastic, megaloblastic, your hemolytic anemia. So there's like different types of anemia, and it is named or being labeled based on the result of an underlying causes. So we will focus on the iron deficiency anemia and the sickle cell anemia. We will talk about that in a little bit. So anemia is an hemoglobin, a number of or a level of hemoglobin below 8 grams per DL. And because of this, it results in an increased cardiac output and a shunting of blood from the periphery to the vital organs. Can result in pallor. I mean, it makes sense, right? You have little red blood cells, so that person is going to be pale. Weakness because of the lack of oxygen that is actually going to the tissues or the organs in the body. Same thing with your tachypnea and your shortness of breath. And eventually, it could also cause congestive heart failure. The heart just simply will fail because of all the workload that it needs to do to correct the situation. Iron deficiency anemia, this is the most common nutritional deficiency of the children. Usually, during infancy, it happens from the 9th to the 24th month. And then also, this is common during adolescence. So this is your two different periods where there's a rapid development, your infancy and your adolescence. So what causes iron deficiency anemia? There could be different causes. It may be caused by a severe hemorrhage from, bleeding, inability to absorb iron that is received, excessive growth requirements, or even an inadequate diet. The most common that is actually causing iron deficiency anemia during infancy is when the child or the infant actually is switched from maybe a fortified formula or breastfeeding into a whole cow's milk in even before they turn 1 year old, because giving whole cow's milk to infants can actually lead to bleeding, GI bleeding that could lead anemia. Even those infant cereals that's actually rich in iron, if you remove it from the diet of the growing child, then it could actually cause iron deficiency anemia. So it's very important to plan like a healthy iron-rich diet for an infant or for a little child to prevent this. Okay, so for maybe preschool or starting in the toddler stage, what we can do is actually plan their diet, and we can give them those food that's actually rich in iron. If you go to page 640 in the bottom side of the left side of the book, you can see in there they give us examples of food that is actually good for to prevent your iron deficiency anemia. What are they? Your boiled egg yolk, liver, leafy green vegetables, cream of wheat, your dried fruits like your apricots, your peaches, prunes, raisins, dry beans, crushed nuts, and whole grain bread are good sources of your iron. Manifestations of iron deficiency anemia The child will be pale, there will be pallor, there will be irritability, anorexia, there will be a decrease in activity, and some infants will or may be overweight because of excessive milk consumption. And we see this very often. Like there would be parents that actually would just sometimes rely too heavily on the giving the feedings to the baby that could lead to the overweight of the infant. All right, because this is a disorder of that actually involves the blood. So we're gonna do some blood tests, right? We're gonna do your RBC count. We're gonna see if it's low, right? Because that could indicate your iron deficiency anemia, or your hemoglobin might be low, and your hematocrit may be high, right? Morphological cell changes is when they're actually looking at the how the RBC is actually presenting, like how it looks, and your iron concentrations in the blood. And then what we're gonna do is we're gonna collect stool. Stool may be tested for what we call an occult blood, and occult means hidden, right? So one thing that we talked about earlier on is anemia could be caused by hemorrhage. So that's why we're checking, if you're looking at the patient and you cannot see anything that could be causing the anemia or the low RBC and the low hemoglobin, then you're gonna see, or you're gonna check the stool and see maybe something is going on inside the GI that is actually not showing or not very obvious. So we can do what we call an occult blood, and if it's positive, then we know that there's some kind of bleeding that's going on in the GI. Right. Untreated iron deficiency anemia will progress slowly, but in severe cases, the heart muscle may become too weak to function, and next thing you know, your patient is going to have a congestive heart failure or heart failure. Children with long-standing anemia may also show growth retardation and cognitive changes. So how can we treat the patient or manage the situation? Well, it's an iron deficiency anemia, so you give them iron. We can order them iron. Usually what we give is what we call your ferrous sulfate. Usually we give it by mouth, and it's 2 to 3 times a day. And very important to remember is that your vitamin C is your best friend of your iron. Make sure that if you can, then give them together. You have to make sure that there's some kind of vitamin C that you're incorporating while you're giving the iron, because vitamin C aids in absorption of iron. So if you're going to give an iron to a patient, to a child, what you can do is maybe you can give them orange juice, right? Orange juice is vitamin C. So it can actually help with the absorption of iron. All right. Also, your liquid preparations for iron, we prefer to give it through a straw because that could actually prevent discoloration of the teeth. So if you're giving it in an older child, maybe preschool up to like adolescent, then you can use actually, or you can give it with straw to prevent discoloration of the teeth. Obviously, in infant, it would be a little tricky to do that. If we're gonna give the iron dextran, or this is what a type of iron medication that could be given IM, intramuscularly, or intravenously, your IV. Obviously, this would be a second option or your last option, because you would always want to give them oral first. Hopefully the baby can tolerate it and it goes with their diet that we can give it by mouth. But if that's not the case, then there's always another option, which is your IM and your IV. But please remember, when you're giving an iron injection, it should be given in a large muzzle and using a Z-track method. Z-track method, because this actually helps with staining and preventing the irritation of the tissue. So you're gonna give it in a Z-track method. We did it during a lab, when you kind of like pull the skin out away from the area of where you're gonna put the needle in or the injection in. And then after you give the medication, you actually let go of the skin to kind of like cover that entrance, that site of injection. Okay, let's move forward. We'll talk about your sickle cell disease. There's two types of your sickle cell disease. There's your sickle cell trait and your sickle cell anemia. Sickle cell trait is asymptomatic, where your sickle cell anemia is the one that's more severe, and we'll talk about that in the next few minutes. For your sickle cell trait, obviously they are asymptomatic, and the blood of the patient contains a mixture of the hemoglobin A and that sickle hemoglobin, or your hemoglobin S. However, this is the difference, that hemoglobin S is actually, the proportion of that is low. So you have just a little bit of that abnormally shaped hemoglobin, and you have the other one, which is your hemoglobin that is normal. This disease is inherited from only one parent. That's why it's not so severe. And when we do the hemoglobin and your RBC count, they're actually normal. So, sickle cell trait, we actually don't have to like treat, or there's like management that is needed because they're asymptomatic, right? The main problem here is that that person is still a carrier, meaning, if they still have the gene, right, to give it to their child. And sickle cell is a recessive trait. So if that person that is a carrier, married another carrier, and they have a child together, and the child actually receives both of those genes from both her mom and her dad, then that's when it's gonna be a sickle cell anemia, which is more severe, because both parents, she inherited, or the child inherited that genes from both parents. All right, so sickle cell anemia, like I said earlier on, is more severe. Clinical symptoms, though, do not appear until the last part of the first year of life. And what we usually see first is those unusual swelling of the fingers and the toes. In adults, you would, hear them that they're actually complaining that, oh, I'm in so much pain, right? There's so much pain because of the blockage of whatever site it is that is being blocked by those sickle cells. For the first year of life, they're infants, they're little kids. So what we're gonna see is those unusual swelling of the fingers and the toes. And this is caused by those enlarging of the bone marrow site, and it impairs the circulation to the bone, and the abnormal sickle shape that causes what we call clumping together, obstructing the blood vessel, and ischemia, causing ischemia to the organ, the vessel supply. Hemoglobin, when we check it, it's going to be ranging from 6 to 9 or even lower. The child will be pale. The child will tire easily. There will be some dyspnea, shortness of breath, and has little appetite. And then if we recall your what we call sickle cell crisis, this is very painful for the patient and it could even be fatal. What will be the symptoms of the sickle cell crisis? There will be a severe abdominal pain, severe abdominal pain. Your patient will be in so much pain. There will be muscle spasms, leg pain, or painful joints, swollen joints, because of those sickle cell that's actually clumping together and obstructing the blood flow to the area. There will be fever, vomiting, hematuria, convulsions, stiff neck, coma or paralysis. And we'll talk about the types of sickle cell crisis in a little bit, but for now, please remember that your vaso-occlusive sickle cell crisis actually put the patient at risk for stroke. Okay, risk of stroke is a complication of a vaso-occlusive sickle cell crisis. Okay, types of sickle cell crisis, please go to page 642. That table in there, your table 27.1, that is types of your sickle cell crisis. Let's familiarize ourselves with these 4 types of your crisis. You have your vaso-occlusive sickle cell crisis, your splenic sequestration, aplastic, and your hyperhemolytic. So what's happening here? For your vaso-occlusive pain crisis, this is the painful one, very painful crisis. But this is the most common type. This is when, like I said, there's an obstruction because of those sickle cell that is clumping together. There's an obstruction of the blood flow. It could cause that decreased blood flow to the area or even blocked it, right? Causing that infarction or causing that ischemia on that area of the body. Painful joints and extremities. Abdominal pain. Why? Because there will be an infarction or bleeding within your organs in the abdomen. Your liver, your spleen, maybe even in your abdominal lymph nodes. Yep. Patient can even have central nervous system strokes, pulmonary disease, or priapism may be present. What we give are those high potent medications because, like I said, the patient is in so much pain. So we're gonna give them your morphine, your codeine, or Vicodin, and we are giving it via IV, intravenous, or something that is actually a rapid acting for your patient. But because of that, please remember we're giving them those narcotics, your morphine, right? That actually depresses your respiratory system. So make sure that we're monitoring them for those adverse effects of those medications after we give it to them. All right, your splenic sequestrations, there's large amounts of blood pool in the liver and your spleen. So 2 sites, right? 2 common sites. Your spleen becomes big, becomes massive. There will be an abdominal pain. There will be a circulatory collapse and shock. And this is actually common between 8 months and 5 years of age. Death may occur within hours of appearance of symptoms if it's not corrected. Aplastic crisis. So this one is when the bone marrow stops producing your red blood cells, and a number of infections may precipitate this event. Usually when the patient actually had a viral infection, there will be a decreased cholestatic count, child will need some kind of transfusion with a fresh packed RBCs if severe anemia actually occurs. Then you have your hyperhemolytic. This one is when there's a rapid rate of hemolysis is superimposed on an already severe process. This one is rare. And progressive fibrosis of spleen reduces its function. Patient becomes more susceptible to infection. So please know the 4 types of your sickle cell crisis and what are the manifestations of these 4 types. Thalassemia. Thalassemia is a group of hereditary blood disorders in which the patient's body cannot produce sufficient hemoglobin, matured hemoglobin. There's 2 types. You have your thalassemia minor and your thalassemia major, which we will talk about later on. What's going on with your thalassemia is your red blood cells. Your red blood cells are abnormal in size and shape, and they are rapidly destroyed. Because of this, your patient is going to have a chronic anemia. In response to that RBC being destroyed, the body will try to compensate itself, and what's it's going to do is it's going to produce large amount of those fetal or those immature hemoglobins. So again, like I said, it's categorized according to the polypeptide chain that is affected. You have your beta thalassemia is the most common variety. This involves impaired production of the beta chains. That's why it's called beta thalassemia. You have the thalassemia minor and thalassemia major. Major is also called as your Cooley's anemia. What are the difference? Difference is that in your thalassemia minor, the trait is actually inherited from the thalassemia gene is actually inherited from only one parent. And for your thalassemia major or your Cooley's anemia, this is when 2 thalassemia genes are inherited from both parents. So between the 2, major is a more serious form of the thalassemia. Okay, manifestations. So what are the manifestations of thalassemia? You're gonna have a patient that is pale and hypoxic and has a poor appetite and may even have a fever. And then the child is going to have jaundice that is going to be mild in the beginning, and then it's going to progress into a different color, your bronze color, and we call this one hemosiderosis. It's HEMOSIDEROSIS, hemosiderosis, and this is a deposit of iron into the tissues. Okay, that's the reason why they're gonna have that bronze color, because of what we call hemosiderosis, which is a deposit of iron into the tissues. More manifestations: the liver will be enlarged, there will be an abdominal distension, there will be a change in the facial contour of the child, and this one is caused by the defects and a massive expansion of the bone marrow in the face and skull of the child. Teeth protrusion is also common because of the overgrowth of the upper jawbone. And then the child is also going to be at risk for fracture because the bone will become thin. And eventually, when the heart cannot take anymore because of the chronic anemia, then the child is going to have heart failure. So how do we manage this condition? Well, the goal of care is to have a hemoglobin to maintain hemoglobin levels at 9.5 grams per DL and to also provide for growth and development and normal physical activity of the child. We also want to prevent infection because the bone marrow is actually affected, the spleen is actually affected, not infected, affected, sorry. So you're gonna want to prevent infection because there's not gonna be any kind of immunity to battle the infection if it does happen. And then one common treatment for your thalassemia is the frequent blood transfusions because like I mentioned, our goal is to actually keep that hemoglobin levels at 9.5 or above 9.5. But here's a problem. There's a lot of problem that could cause from blood transfusions, right? Allergic is one, right? Maybe there's going to be a reaction towards the blood transfusion. One common reaction that we actually see is your excessive deposits of the iron in the tissues, which we just did talk about, your what we call hemosiderosis. So you're gonna want to monitor your patient that's actually receiving blood transfusion. Okay, now that we're talking about blood transfusion, so what do we actually monitor for blood transfusion? Um, what we're monitoring for are those signs of transfusion reaction. And what are they? We're monitoring for itching, chills, headache, back pain, rash, or even fever. Okay. And what do we do actually? For example, you have a patient that is receiving a blood transfusion and you're the nurse taking care of the patient. And patient told you, oh, I have a back pain or I'm itching everywhere. So that's one sign of a blood transfusion reaction. What you're gonna do is to stop it, clamp off the blood, clamp the tube, so the blood flow to the patient is actually stopped. So you clamp it off, and then you're gonna want to keep the line open with normal saline. Okay, so clamp off the blood, but keeping the line open for with the normal saline, and then you notify the charge nurse. All right. So, hemophilia. What is hemophilia? Hemophilia is an inherited sex-linked recessive trait. The problem here is clotting factor, okay? There's a problem with clotting factors. There's a defective gene. It's located on the X or female chromosomes. And there's two common types. Your hemophilia B, which is a factor IX deficiency. We also call this Christmas disease. And your hemophilia A, which is a deficiency in factor VIII. Okay, please remember those two types of your hemophilia. Hemophilia B, which is a Christmas disease, a factor IX deficiency. Hemophilia A is a deficiency in factor VIII. And a deficiency in any one of the factors will interfere with normal blood clotting. We know this. Hemophilia A is caused by a deficiency of your coagulation factor VIII, which is one of your clotting factors. And the severity, it depends on the level of the factor VIII that is in the plasma of the blood. And like we said, it really depends. Some patient may be okay and may just have like bruises whenever they bump into something, or some patient can actually their lives can even be endangered just by a minor cut because the ability of the patient to actually stop the bleeding because there's no clotting factors. There's a problem with the clotting ability is so severe that they could even die. It could even be fatal for them just because of a minor scratch or minor cut. Aim of therapy is to increase level of factor VIII, obviously, to ensure that there's enough clotting. And what we do is we check what we call partial thromboplastin time, or your PTT. This is a blood test to check the time of how long the blood is actually clotting. Manifestations of hemophilia usually can be diagnosed at birth because factor VIII cannot cross the placenta and be transferred while they're still inside the womb as a fetus. In a normal person, blood clotting is 3 to 6 minutes. In severe hemophilia, the blood clotting time is actually so long, it can even take up to 1 hour or even longer. And again, the blood tests that we order for these patients are what we call your PTT, your partial thromboplastin time. Manifestations of your hemophilia, you're gonna have anemia, leukocytosis, maybe an increase in the platelets. There will be signs of shock. Hematuria is common. Hematuria is a blood in the urine. That, like we said, can result from excessive bleeding because of the inability of the body to actually stop the bleeding, clot the blood, especially if that bleeding is actually occurring in the brain or in the neck. Severe headache, vomiting, and disorientation may be symptoms. Idiopathic thrombocytopenic purpura, or your ITP. This one is an acquired platelet disorder that occurs in childhood. Cause is unknown, but they believe that it's actually something to do with it's an autoimmune reaction that has something to do with a recent viral infection. So here's what's happening with ITP. The platelets in the body is becoming covered or coated by an antibody, an antiplatelet antibody. And because of that, the patient's body is registering that platelet as something that is foreign, something is not supposed to be in there. So what's going to happen is the platelets are being destroyed by the spleen. Because of that, then you're going to have all those problems with the low platelets. ITP occurs in all age groups, but main incidence is between your 2 and 4 years of age. Manifestations of ITP, so connected to the pathophysiology of the disease, is that the own body is actually destroying the platelets, so there's not much platelets going around. So the classic symptoms would be easy bruising, right? There's even what we call a petechiae dorsi minute bruising or bleeding, and purpura, which is the kind of like the petechiae but a little bit bigger. May have recent history of rubella, rubeola, or viral respiratory infection, because again, ITP is believed to be triggered or to be started by something that is caused by a virus, like a viral infection. Platelet could go down to 20,000 even, right? The normal range, if we recall, for platelet number is 150 to 400,000 millimeters cubic millimeters. For your ITP, the platelet is really down. It's really down, that could go all the way down to your 20,000 cubic millimeter. How do we diagnose it? Diagnosis is confirmed by bone marrow aspiration. And if you look at the book in page 648, figure 27.7, that is how a bone marrow aspiration is being done. And this is actually how we're going to help to position the patient. Treatment for ITP usually not indicated in most cases. If it is, there's prednisone, IV gamma globulin, and anti-D antibody. Those are some treatment options. In severe or chronic cases of ITP, we can even do a what we call splenectomy, which is when we remove the spleen, because we remember that spleen is the one that's actually destroying those platelets. Okay, very important to remember neurologic assessments. This is a priority of care. Why? Because with your ITP, platelet is low. When the platelet is low, there is a great danger for intracranial bleeding. And intracranial bleeding, what you're gonna see is a change in neurologic status. So we want to catch that right away. You want to monitor neurologic status of the patient so that we can correct it right away. Okay. All right. So drugs to avoid. You want to avoid those drugs that's actually interfering with the action or the platelet function, like your aspirin, phenylbutazone, phenacetin, and your caffeine. Activity is limited during acute states to avoid bruising. Platelets are usually not given because they are destroyed by the disease process, so it doesn't make sense for us to be giving platelets. We want to correct the situation by removing the spleen or giving a medication that could actually help, but not giving platelets, because platelets, if we give it, it's just going to be destroyed. Complications, I mean, it's very clear, right? We're dealing with platelets, low platelets. So you're watching for bleeding. So complications of ITP, bleeding from the GI tract, hemarthrosis, which is bleeding of those joints, intracranial hemorrhage, bleeding in the brain. Prevention may be helped by immunizing all children against the viral diseases of childhood, because again, ITP is believed to be triggered by a viral infection. Disorders of the white blood cells. So the most common form of cancer is your leukemia. Refers to a group of malignant diseases that affects the bone marrow and the lymphatic system. We classified them based on what type of white blood cell is affected. So you have your acute lymphoid leukemia, or ALL, your acute non-lymphoid or myelogenous leukemia, AMLL, or AML. Leukemia is a malignant disease of the blood-forming organs that results in an uncontrolled growth of immature white blood cells. The patient will have an abundance or overproduction of the immature white blood cell. Because of that, there's going to be a disruption of the bone marrow function, because these immature white blood cells are taking over that space of inside the bone marrow. And that bone marrow is actually the ones that's responsible for the formation of red blood cell, and because of that, then anemia will result. Platelet counts also will be affected and will be reduced. Invasion of the bone marrow causes weakening of the bone. Therefore, that patient is now going to have pathologic fractures. Manifestations. What are the common symptoms of your leukemia? There's going to be, in the initial phase, which is in the early stage of the leukemia, there's going to be low-grade fever, pallor, bruising tendency because of that reduced platelet, leg and joint pain because of that overproduction of that white blood cell and overburdening that bone marrow of the bones, listlessness, abdominal pain, enlargement of lymph nodes, and anemia because of those um, overproduction of the white blood cell that's actually in the bone marrow. So manifestations could be gradual or sudden onset. Eventually, the liver and the spleen will become enlarged. It will be affected. Skin will have this lemon yellow color. Petechiae and purpura could also be present. Anorexia, vomiting, weight loss, and dyspnea are also common. Diagnosis is based on the symptoms of the patient and the history. So when the patient comes in, you're going to take the history and what are those manifestations that the patient is actually showing. And then we're going to do extensive blood tests. We did talk about that there's going to be an overproduction or abundance of white blood cell, but they are immature. So there's going to be presence of leukemic blast cells in the blood, in the bone marrow, or even the tissues. We're going to do some radiographs. We're going to do some x-ray, CT scan, MRI of the long bones to see the bone marrow. Spinal tap is done to check for CNS involvement. Kidney and liver function are also being checked because, like we said, eventually kidneys and the livers are being affected, and there's going to be an enlargement of the kidney and the liver. The adequacy of their function is essential to the outcomes of chemotherapy. So, after you diagnose the patient, then you're going to think about those treatment plans, and that involves chemotherapy. So, you would want to check if the kidney and the liver function are still okay, because if they are, it's very important. Once the child starts doing the treatment, the adequacy of the function of the kidney and the liver is very, very important. So, radiation and chemotherapy, those are the treatments that we're gonna do for leukemia. And what they're gonna do is they're gonna target those infected cells, right? We're not gonna go over those components of the chemotherapy, but just know that if the patient is actually having or there's an ongoing radiation and chemotherapy, please remember that that patient is actually at risk for not only bleeding but also for infection because you're actually targeting those sites that actually is involved with the production and formation of the red blood cells and the white blood cells and even platelets. So if you don't have those things that actually helping us with the bleeding, with the blood clotting, or fighting infections, then that actually put those patients at risk for bleeding and infection. Bone marrow transplant, again, what's infected here or affected here is the bone marrow, right? So if it's very severe that radiation and chemotherapy is not enough, then we might need to do some bone marrow transplant. And these are the side effects of your chemotherapy. They can cause nausea, diarrhea, rash, hair loss, fever, anuria, anemia, and bone marrow depression. Okay, you're gonna want to encourage the child to verbalize their feelings. This is really hard time for a child, right? Children, as we know by now, they should be out there playing, right? They should be discovering the world around them, their environment, building relationships with their parents or friends from school, right? So this is going to be very hard for the child. They're gonna be in the hospital. They're gonna do treatment after treatment after treatment, and it's still very important for you to make sure that you're taking care of the growth and development of the child, not only physical but also for their mental health, right? So you want to encourage the child to verbalize their feelings. Give permission to discuss their concerns to you. If they ask you a question, make sure that you're doing some clarifications, validating their feelings, right? Validating what they feel, validating if they're saying that they're in pain, they're having so much trouble. Um, Make sure that you're actually taking care of them. Frequently observing the child for infection is very important because we did mention they're at high risk for infection. monitoring vital signs and for symptoms of bleeding, meticulous mouth and skin care, very important. Hodgkin disease, or also known as your Hodgkin lymphoma. This is a malignancy of the lymph system that primarily involves the lymph nodes. If you guys recall what we call Reed-Sternberg cells, those are those weird looking cells. That's actually a giant multinucleated cells. The presence of that is the diagnosis of the disease. Okay, it may metastasize to the spleen, liver, bone marrow, lungs, or other parts of the body. Usually, there's a painless lump along the neck, along with any some other manifestations like your low-grade fever, anorexia, unexplained weight loss, night sweats, general malaise, your rash, and even itching. Rarely seen before 5 years of age, incidence increases during adolescence and early adulthood, and twice as common in boys as in girls. Treatment of Hodgkin lymphoma is either radiation and or chemotherapy, but it's based on the clinical stage of the disease upon diagnosis. Long-term prognosis is usually excellent. Nursing care of patients with Hodgkin lymphoma. Remember that these patients are actually going for radiation and chemotherapy. So, the care is mainly directed towards those symptoms or relief from the symptoms of the side effects of your radiation and your chemotherapy. Education of patient and family regarding the disorder itself and the treatment that they're receiving. Malaise is common after radiation therapy. The child usually tires easily. They may even be irritable and they have poor appetite. So we got to make sure we get the nutritionist involved, making sure that we're giving them proper nutrition. Skin is in treated area may be sensitive and must be protected against exposure to sunlight and irritation. The patient does not become radioactive during or after therapy. Very important to remember. When providing emotional support for the patient with a Hodgkin lymphoma, we gotta make sure that the support that we give is age appropriate. Activity is generally regulated by the patient, not you as the nurse or not the clinician. Also, we gotta educate them that appearance of your secondary sexual characteristics or your menstruation is actually delayed with this one, and sterility is often a side effect of the treatment. Those are the things that we have to educate our patients on. And that concludes chapter 27.